Morning, everyone. Welcome to the session on Principles and Designing of Cast Partial Denture. Have you ever asked why cast partial removable dentures have not enjoyed overwhelming acceptance in the past years? Let's understand. Most of you are familiar with the Leaning Tower of Pisa. It's famous for its unintended tilt as well as unstable foundation because of its design. Now, considering this analogy to the cast partial denture designing, definitely an improper design will lead to cast partial denture failure and also compromises the remaining teeth and surrounding tissues. So it's important for us to describe the biomechanical considerations in CPD design, integrate the design principles to construct the optimal CPD in this session. As clinicians, all of us have to follow the dictum given by Devan, which is the perpetual preservation of what remains is more important than the meticulous replacement of what is missing. In 1956, some basic principles were laid by Smith, and he emphasized the need of complete examination, diagnosis of the patient, proper plan of treatment, as well as periodic recall during CPD designing, and stated that removal partial denture is a form of treatment and not a cure. So if an RPD is a part of your planned treatment, you should plan the RPD before beginning any other treatment. Also, it's important to visualize the final treatment outcome way ahead in the first appointment itself. Now, coming to the steps in planning of our CPD. So it starts with diagnosis and treatment plan, followed by the diagnostic cast, and some considerations if required for the mouth preparation, as well as altered cast impression if needed. Finally, last but not the least, after following all the steps, we need to have the recall. So for ease of discussion, I have try to go ahead considering this mandibular partially edentulous condition for the discussion. So to begin with, we need to have a note on the color coding for CPD design, the brown for the metal components, red for all the preps, and blue for the acrylic components. So what are the key questions that needs to be considered while you're charting a CPD design? So here I have laid down 16 questions which have to be promptly answered to get an effective design. Let's take them one by one across the session. The first key question, are there any limiting occlusal considerations? In order to in order to answer this, you need to evaluate the patient's intraoral conditions for all of these or beyond, and also determine which mechanical and biological principles along with design philosophy in CPD will work best for that particular situation or patient. So then, which are the mechanical and biological principles that need consideration? So as dentists, remember, we need to also have some knowledge of physics and engineering so that we can apply that to understand the lever, the fulcrum lines, as well as the force in terms of duration and magnitude as they act on the teeth and the residual alveolar ridge. So the first type of lever that we want to discuss over here is the class 1. This is appreciated in distal extension RPDs, and as seen over here, this follows the principle of a seesaw where the fulcrum is at the center. So on function, there would be an occlusal force exerted on the denture base, and what happens, there is a resistance that is being given by the tip of the retentive arm, which engages the undercut, tries to lift as well as it transmits lateral forces onto the abutment teeth. So how do we control this type of a lever? By trying to have the right design of direct retainers in our cast partial denture designing. Next is the class 2 lever. This is again appreciated in distal extension, and it can be related to a wheelbarrow where the fulcrum is moved towards one end. So again, on function, for example, if a patient here is biting on a sticky foot, what happens? The denture lifts and the fulcrum here is far anteriorly as possible. So what do we do to control this? We have to place an auxiliary rest such that it prevents this lifting of the denture base. So it's important for us to consider indirect retainers to counteract the class 2 lever. Since class 3 levers are not there, we go ahead considering the next simple machine, that is the inclined plane. Now, where is it considered? In designing or constructing our occlusal rests and our seat preparations. It is advocated that always the rest seat should be lesser than 90 degrees in its angle. Or else, if it is more than 90 or above, what happens? It magnifies the stress that is transmitted to the abutment teeth. Next, going ahead to the fulcrum blinds. These are definitely seen in distal extension partial dentures, and hence it is challenging to design distal extension CPD. While in cases of tooth-supported RPDs, it is rarely we appreciate the rotational forces. Now, which are these fulcrum lines? Firstly, the horizontal fulcrum line. As seen over here, this extends from the terminal abutment occlusal rest on one side to the other. And you see it in the horizontal plane, and the forces act on the sagittal plane. So this is difficult to control, and the magnitude of rotational movement is greatest around this fulcrum. But remember, it is not most damaging. Why? Because fibers of periodontal ligament are better equipped to resist vertical forces than horizontal forces. It is also said that more number of fibers get activated during vertical forces rather than the horizontal forces. Next, going to the next fulcrum line, that's the sagittal fulcrum line. So where does this extend? It extends from the occlusal rest seat of the terminal abutment on one side and also on the other side across the crest of the alveolar ridge. Now this controls the rotational movement in vertical plane. And the movements here are easier to control, lesser in magnitude, but more damaging because they are directed in a horizontal direction. The next and the last fulcrum line is the vertical fulcrum line. Now, this is located in the midline, lingual to the anterior teeth, and palatal in the maxillary anteriors. This controls movement of the denture in the horizontal plane, that is, it leads to flat circular movements of the denture. Now, to summarize, as we understood, we have to make a note of the fulcrum lines because of its rotational movement that it causes on the RPD, especially in the distal extension, class 1, class 2, and also in class 4. Now, how do we counteract that? We have to have an indirect retainer that is placed perpendicular to the fulcrum line. As seen here in class 1, we cannot use the central incisors or the lateral. So what we do, we place the indirect retainers, that is the res, on the canine or sometimes on the premolar as well. And in cases of class 4, we try to place these indirect retainers as far posteriorly on the posterior abutments. Now coming to the RPD design philosophy. Of the various schools of thought, none of these philosophies are backed by scientific research or statistics. They're all ideas of dentists who have extensive clinical experience, and they have formulated some rules which they have produced a design. So if physiological limits of the supporting tissues are respected, then remember, almost any design can be successful. But definitely the challenge lies in designing the class 1 and the class 2 arches, and to a certain extent in the class 4 arches. Why? Because we need to ensure distributing the forces acting on the RPD both between the soft tissues as well as on the teeth. Now the first type of philosophy believes in the concept of stress equalization. So it advocates transferring the load from the abutment to the ridge. Remember, it says that the displaceability and the resiliency of a tooth which is secured by periodontal ligament cannot be compared to that of the mucoperiosteum. And hence, in order to transfer this load from the abutment to the ridge, we need to ensure the incorporation of hinges, sleeves, ball and socket as seen over here. Or we can also have a flexible connection between the direct retainer and the denture base. So what happens? whenever you have a force exerted and the denture base lifts up and down, we have it here at the hinge and there is no force transferred onto the abutment teeth. Kindly note the advantages and disadvantages. Lack of time, so I would not be going ahead detailing on it. The next philosophy is the physiological basing. So this believes in stress equalization of how? By displacing or depressing the rich mucosa during impression making procedure. So here we have a mucocompressive impression such that the tissue surface is recorded in the functional form and not in the anatomic form. We can also try to reline the denture base after it has been constructed for ensuring stress equalization. As seen here, in function, the prosthesis is properly fitted, but at rest, it lifts up. Therefore, to permit vertical movement from rest position to functional position, the retentive clouds have to be minimum, and also the number has to be less. Again, note the advantages and disadvantages of this philosophy. Going further, broad stress distribution is the next important philosophy all of us follow. It's advocated by all textbooks. And how does this act? This is achieved by distributing the forces of occlusion over as many teeth as possible and also the available soft tissue area as possible. So, how do you achieve it? By means of additional rest, indirect retainer, clasp, and broad coverage denture bases. Note again the advantages and disadvantages of this philosophy. So here, the advantages is teeth can be splinted and also the processes are easier and less expensive. No flexible or moving parts is involved, and this also exhibits excellent horizontal stabilization. The disadvantages basically being the greater bulk and also increased amount of tooth coverage, which can lead to dental caries. All this while, we try to look into the types of forces. But now, we will try understanding how this magnitude of force will try to have its characteristics over the teeth and the edentulous area. First, considering the length of edentulous span. Greater the length of the span, greater the force. So, it's important for us to preserve the posterior teeth much ahead and much before the extraction of, much before they're indicated for their extraction. Why? Because rotational movements increase with the length of the span of the distal extension. Another important characteristic that has to be remembered is the quality of supporting tissues. So it is said that large, well-formed ridges are capable of absorbing greater amount of stress. Also, they provide good stability, while the flat ridges provide good support but poor stability. Sharp spiny ridges, they offer poor support and also poor to fair stability. Soft, flabby, displaceable tissue again offers poor support and poor stability. Is it important to look into the type of mucoperiosteum? Yes. Why? Because it influences the magnitude of stresses transmitted to the abutment teeth. It is said that healthy, thick mucoperiosteum, it is better than atrophic. Now coming back to our ideal situation, we do not have any occlusal considerations to be mentioned here because it's an ideal situation. Coming to the mechanical principles of lever, we need to counteract them in our design for the class 1, class 2, and also the inclined plane effect on the rest seat. And also counteract forces across horizontal, sagittal, and vertical in our design. The philosophy that we would be considering is the broad stress distribution. Now, here is one MCQ, which you need to know. Go ahead and can solve it. The stem being the philosophy that aims to preserve remaining structures by distributing occlusal forces evenly between teeth and tissue is known as. The options are mucosal support concept, tooth support concept, stress equalization philosophy, physiological basing philosophy. Kindly place your answers in the chat box. I hope you've done it. Let's look into the answer. The answer is C, stress equalization philosophy. Now moving ahead. Let's go into our second question, the most easiest. Determine Kennedy's classification supplemented by Applegate's rule for the modification spaces. I suppose all of you are familiar with this. So the answer for our ideal situation that we considered here, that is Kennedy's class 1 with no modification spaces. Now moving on to the third question. Is the association that we are treating or we are intending to designing for is tooth supported or tooth tissue supported? To understand this, we need to have some key points of comparison between these two scenarios. Under the headings of the support derived, the impression technique, the indirect retention that is required, the base materials, and the stress breaking elements. As already mentioned, we need to have a functional impression whenever we have a tooth tissue supported condition. And we also have to consider indirect retention. Base material, we generally use the acrylic for ease of relining. And when it is a long span, we may have to consider stress breaking. So now, the support for distal extension RPT depends on the following factors of contour and quality of residual ridge, extent of residual ridge coverage by the denture base, type and accuracy of the impression, accuracy and fit of the denture base, design of the removal partial denture framework, and the total occlusal load that is applied. So now coming back to our ideal situation, this is a tooth tissue supported condition. So we have to plan in advance the indirect retention and also consider functional impression with acrylic base as our material. Let's now again break for another MCQ. Let you answer which principle prevents movement of the denture base towards the tissue. Kindly type your answers in the chat box. Hope you've identified it. Answer is support. Why? Because support is the resistance to vertical forces directed towards tissues. Now moving further. The next question we need to answer is, which are the primary abutments we are considering in our design? So it's important for us to understand that these teeth receive a significant portion of our occlusal forces directed at the missing teeth as well as on the residual ridge. So the tooth that are directly adjacent to an edentulous space serves as the foundational support for the prosthesis. We should also ensure that they possess the necessary characteristics to withstand these stresses. That means they need to be periodontally sound. Simultaneously, you should also remember to consider the abutment tooth surface, whether it is restored or it is with natural enamel. Why? Because greater stress is exerted on a tooth restored with restoration than on a tooth with intact enamel. So in this ideal situation, the primary abutments that we would consider are the premolars, that is the second premolars on both the sides. Moving on. The next question, where are the undercuts located for the teeth and what is the appropriate anterior-posterior tilt that is required? So for this, you need to have good knowledge about the surveying tools and mouth prefs. Lack of time, I would not go into details of it. But some key points to mention, you have to remember that the horizontal tilt that is used should be less than 10 degrees. And also, you have to remember that you're supposed to go ahead and consider locating the best of the combination of retentive undercuts. And also, you need to go ahead, record the contours as well as the relative positions of the abutments and also the associated structures. And one more important point to mention here is you need to ensure that the carbon tip marker should be placed at the gingival margin or else you may not register the right height of contour. The next question is the path of insertion. What are the number of guiding planes that you've located? and what is the depth of the undercut. So here you have to remember that this depends, that is, the optimal path of insertion is determined by equalizing the retentive undercuts for all abutments and also eliminating or even minimizing the number of interferences in our path of insertion, and trying to have the placement of the artificial teeth in the best of its aesthetics, and removing by trying to limiting the number of guiding planes, by trying to ensure that there is limited movement both while insertion, removal, and function. So points to be noted: this path of insertion is always parallel to the vertical arm of the surveyor and is determined by the tilth. In cases of tooth-bound edentulous cases, we always appreciate a single path of insertion, and cases of class 1 with two distal extension cases, we may have a multiple path of insertion. But one thing that we have to remember always is, in any case of designing a removable partial denture, we need to always fabricate it such that there is a single path of insertion or removal from the mouth. Why? Because this is important to equalize the retention on all abutments and provide cross-arch stabilization, minimize torquing forces, and also ensure that the forces are directed along the long axis of the teeth, and also because it provides frictional retention from contact of parallel surfaces of the teeth. So here, again, some key points to remember. Whenever you're trying to measure the undercut gauge, you should always ensure that the lip as well as the shaft or both try to touch the teeth. Otherwise, you may again go wrong. And also never forget the tripoding for reorientation of our cast for future surveying. Coming back to our ideal situation, so the identified path of insertion here ensures that we have to have guiding planes on 3, 5, and 4, 5 on the distal proximal surfaces, and the undercuts identified is the distobuccal undercut on 3, 5, and 4, 5. You may ask, why not a mesiobuccal undercut? Let's try to discuss that in our section of class designing. So I have another important MCQ here. Try identifying the answer. So the path of insertion for single distal extension with tooth bounded space on opposite side is options: single path of insertion as rigid major connector must follow the tooth bound side, multiple path of insertion, and C, determined by guiding plane on edentulous span. So what's your answer? Let's check it. The answer is A, it is determined by modification space.